Stefan, thank you very much for having invited me here to this very interesting webinar. I think it's a kind of our future that we have to learn to do simulation because as we all know, we cannot learn with the patient or on the patient. We have to train our skills beforehand, I think. And for that reason, we wanted to try to give you an insight how simulation can take place in the cath lab and how we can simulate a real case scenario. And this is filmed before this webinar, and I want to show now the video. So please give us the video. Dear colleagues, welcome to the University of Gießen. It's my pleasure to welcome you to this cath lab to present you today live in a box case, multi-vessel disease with complex left main stenosis. I want to present you the clinical history of our patients today. It's a 78-year-old male patient with de novo angina in class CCF3. There are no previous cardiac events so far in this patient, but there are typical cardiovascular risk factors like hyperlipidemia and hypertension. There's a normal baseline ECG in this patient, and the TTE shows a normal regional wall motion with no disease in the aortic and mitral valve. Next slide. There's a quite normal laboratory investigation, nothing specific. And if you look now at the angio, you can see the intermediate stenosis of the RCA in the mid part, which we have to evaluate if there is any hemodynamic relevance. And if you go to the left coronary system, you may appreciate that there is a left main disease, which is around 50%. Of course, we have also this proximal LAD stenosis, which seems to be hemodynamic relevant, and we have the intermediate stenosis in the mid to distal part of the LAD. If you look at this area caudal, you may appreciate that the circ is not affected. However, I think we have to evaluate whether by functional testing or intravascular imaging, whether the circ is also diseased at the ostial part or not. Looking at the syntax risk score, you have the Euro score 2 of 0.78%, and the angiographic. So remarkable, you have to know that the angiographic syntax score is 19. And now I want to present you the team today. It's of course the hemodynamic assessment done by David, and I have help here on the table, which is done by Jonathan. And the special thing today is that we have not a real patient, we have the Mentis VIS simulator here, which is only present as a virtual patient. However, we have this possibility to feel like in a real environment. We can steer our C arm like in the real world, and the table is connected with our simulator so that we always feel like in the real cath lab scenario. This brings us to the strategy. We want, of course, as I mentioned before, to do the hemodynamic assessment by FFR. Think about the right coronary artery. We want to assess whether these stenosis is functional relevant. Of course, we have to assess the morphology of the bifurcation stenosis. We want to know whether the circ is affected as well, which is the Medina class of this stenosis. From the angiographic view, we think that it's a Medina 101. So we have then, coming from this information, we have then to define the bifurcation strategy. And of course, we want to do this live in a box case also to improve our technical skills. So you can here see the right coronary artery, which shows this intermediate stenosis in the left anterior oblique. So we did also the aerial view. So here you can see nicely the affected mid part of the right coronary artery, showing an intermediate stenosis. And the question is, of course, whether this stenosis is relevant or not. So for that reason, we did already, for the sake of time, the functional assessment with an invasive FFR. And as you can see here, there was an FFR of 0.98, demonstrating that this stenosis is not functionally relevant. Coming to the left coronary artery system, so if you look here in this areocranial, you can appreciate that we have this intermediate stenosis in the mid part of the LAD, and also, as mentioned, the proximal stenosis, as you can see here. If we go in the caudal view, you may appreciate the stenosis in the left main, as well as the proximal part, which is, I guess, severely affected, so that we might have to treat this lesion. The question is also whether the circ is diseased in the ostial part. From this caudal view, we do not think that we need to address also the ostial circ. However, I think for better understanding of the morphology of the stenosis, we have to go for the endovascular imaging first. Secondly, we have to assess the functional relevance of the ostial disease. For that reason, we have to measure now the FFR, and we want to do that live. So I just have here pre-mounted the FFR guide wire, and we can now place the guide wire in the circ coronary artery. Now we are in the distal part of the vessel, ready for functional assessment. So we start the recording of FFR. It's very important that we not engage our guiding catheter, because otherwise we measure maybe false values for FFR. However, I think now we have a nice curve. So there's a clear fall of the PD to PA. We now demonstrate that the left main stenosis is relevant. So now we have to define our strategy. And for this, we need the intravascular imaging. And we have the wire already inside, so we can assess the morphology with the IBUS. So this is the IBUS from the circ, coming from the distal circ, and now we are approaching to the left main, and the question was whether the ostial circ here is affected, but it's not. It's clearly without any disease, and here's the left main. This is the tight stenosis in the left main, which is here measured with an MLA of 5 square millimeter, which is clearly below 6. And then we go to the ostium of the left main, which is clearly normal. If we look at the IBUS of the LAD, of course we have this tight stenosis. There's an MLD of 3.0 square millimeters, which might be enough. That has to be evaluated by functional assessment after treatment of the left main. And then we come to the proximal part. If we measure here, so I guess we are maybe relevant. However, the area is 5.0 square millimeters, which is looking at the correlation of pathologic FFR with the MLA, probably enough. And here comes the left main. This was already assessed by the IVUS from the circ. So to conclude, we have a normal circ. Of course, we have the clear pathologic problem in the left main with a MLA of 5.0, which is, in my eyes, clearly significant. And we have a rather intermediate stenosis with an MLA of 3.0 in the mid to distal part of the LAD. From an intravascular imaging perspective, I would only stand at that point the left main, and then we have to assess the stenosis in the LAD to decide whether we have to stand there or not. So now we have chosen a balloon for predilation in the left main of the shaft of the left main. It's a 3.512 millimeter, and I think this is perfect here. Actually, we can go a little bit more back and disengage. So I think this is not bad. We can change the projection because of the synchronization of the C-arm with the simulator. So we have also this real world scenario that our projection is changing there. Then we can predilate here. Okay, it's coming there. I think it looks good. So the next step is, of course, that we have to implant the stent. So we go into the IVUS again and just measure our dimensions. This is the MLA and the dimension of the left main. It's 5 over 4.7, which means a reference vessel diameter of 4.85. Okay, so that we can choose a 4.5 stent, I think, and then we can just adapt to the pressure, with the pressure to the diameter. Here comes now our stent, as you can see here. So we have to position a little bit better. We have chosen a 4.5 over 12 millimeter coming from our measurements with the IVUS. Okay, we are almost there. We have also to cover the ostium of the left main. Therefore, we have to change our angulation. I think that's not bad. So we cover also the ostial left main. So please inflate. There we come. Yeah. Okay. Go up to 10. 5, 6, 8, 9, 10, 12, 14. So hemodynamics keep stable, so we can remove and we'll do ejection again. But for that, we change again to the callable position. Wow, this is not bad. This is now the IVUS of the stent, and as you may appreciate, at least half of the stent is very well opposed. There is no malapposition and no unexpansion, and we are almost close to the ostium there. The second thing we have to check is the FFR. So we are doing now the FFR of the LAD. We measured the FFR of the LAD finally. As you can see, there is a value of 0.89, which is not relevant, so that we actually are finished and we can conclude. This was a very interesting case. Firstly, we have seen that functional assessment is always very important to find the strategy at all. So we could demonstrate that the right is not affected, but the left main. Secondly, intravascular imaging guide us through the procedure. In this case, we have seen that the distal left main, the ostial part of the LAD, as well as the ostial part of the circ, was not affected, only the shaft of the left main, so that we could only concentrate on the left main. And finally, we had to reassess the functional relevance of the LAD again, showing that there was no pathologic effect of the residual stenosis. This was completely radiation-free, which is one of the important advantages of the system. And I think with the system, we can really improve our skills, not only from the inexperienced young colleagues, but also from the experienced physicians. They both can transfer their skills to the real world scenario. And so, of course, we are doing fewer errors, and the patient is in the focus, not the system in this environment. Well, I hope you enjoy this nice case presentation with this unique interplay between an endovascular simulator and the real system here. I thank you again being guest here in our cath lab in the University of Gießen. Goodbye.
Well, thank you, Holger. I don't know whether you can hear me. I think this was a typical Holger Nef, right? Fantastic skills manually, and at the same time thinking ahead, explaining in clear language. It's always extremely impressive what you do. And I think we've always also seen that there's an impressive interplay of machinery and engineering here. On one hand, the simulator, and on the other hand, the cath lab, to make this as realistic as